Well, we're gonna share the slides. And how much time do I have, yeah, Dr. Amr?
15 minutes.
15 minutes? Yeah, that's too,
50
that
minutes
is
يا
too,
دكتور.
what's that?
30 دقيقة يا باشا.
طب وعشان خاطري. ماشي. Okay, I'm gonna go through the slides very, how many of the audience are surgeons and how many are medicine? Average. So I can,
But online maybe a lot of surgery.
lot of surgeons. Okay, I'll focus on the surgical part. I will try, you know, we're gonna discuss in brief a field that neglected for many years, called gut failure. And you know, we love and hate our gut all the time. And you all know also the intestine has a gut of its own, has a brain of its own. And yeah, and برضو we always have to consult with our gut. يعني نستفتي قلبنا بس برضو نستفتي المعدة بتاعتنا. This is a very important slide to me that Josh Belling من حوالي 100 سنة أو أكتر come to the conclusion in جزء كويس من الأمعاء is a lot worse to a man and woman than any quantity of brains, which indicates to me that over the centuries, everybody knows that the gut is as important to the human being as the brain. You can see the connection here between the gut and the brain. And for our gastroenterologist who is coping with the recent evolution of the field, that the microbiota and the gut neuropeptides play a major connection between the gut and the brain. This is the slide I made a few years ago to emphasize the importance of gut homeostasis in the whole body energy equilibrium. If you lose equilibrium into one side, you develop morbid obesity. And if the other side, you become an Egyptian mummy, as you can see in your right hand side here. And about 30 years ago, I made these slides because there was nothing in the medical literature defining what gut failure is and what are the types. And that you can see here, I divided into 5 types. Short gut syndrome, which everybody familiar with, acquired or congenital, and you got the dysmotility syndromes, which I'm seeing a lot of patients in Egypt now and the Middle East that I have not seen before, and they're being misdiagnosed because most of our physicians and surgeons in Egypt and even worldwide, they're not very familiar with the syndrome, even though those in the United States. Neoplastic disorders we are familiar with, congenital or hereditary, and the intrasite dysfunction after irradiation and congenital anomalies, and those with portomesenteric vein thrombosis. For the short gut syndrome, which constitutes about 80% of the patient who come with gut failure, and for those who are not familiar with the word gut failure, mean these patients requiring intravenous nutrition and TPN, which is a shame for all of us. We still don't have a very well-established system in Egypt for home parenteral nutrition. You can see the causes in adults are different than in children. Most of the adults are acquired, and the children usually congenital. On the your left-hand side, the adults, something you see it when very common, or not very common, but it's really, can you answer this? Is also there is a lack of knowledge about the vascular occlusion. When we were in the medical school, most of these patients were old people with arteriosclerosis. Now we get a good number of patients, young patients, even kids, they have vascular occlusion due to a hypercoagulable state. And that's, yeah, I know some of you know that even the factor V mutation had a high prevalence in the Middle East, particularly in Egypt, up to 20%. It could be silent, or it could manifest it with acute occlusion of the mesenteric vessels. Crohn's disease also, it's becoming a pandemic in Egypt now, and most of you now are familiar with. And I think you guys gaining more and more experience with the disease that I never seen when I was in the medical school in Egypt. Abdominal trauma and the other thing, and the pediatrics, very familiar, gastroschisis, intestinal atresia, etc. This is the important slide that when you lose or you resect part of the gut, you need to know that the intestine go through the adaptation phase. And this is a process, I hope one day when I permanently reside in Egypt, then I teach the new generation how to take care of these patients. The evolution of the field started in 1960 when there was no treatment for patients when they lose the gut. And then TPN came in the 70s. And then there was some medical surgical treatment trials in the 80s. And the 90s, we developed the intestinal and multivisceral transplant. I call it gut transplantation now. And then in the 20s, I introduced the notion of the gut rehabilitation. And I'll show you some of the slides later on. The guy, Stanley Didrick, which the one who was behind the development of TPN for the babies who were dying from severe malnutrition. Unfortunately, I met him once, and we had a dinner together a few years ago. Unfortunately, he passed away last year, and he was he pioneered the development of TPN. And when I was introduced to him, they said, "This is the one who's trying to get rid of the TPN that you developed." And in the 1990s, I was in the right place at the right time, and we developed a drug called Prograf, or FK506, in the 1990s. And from that time, we were able, or I was able, to develop the program of intestinal multivisceral transplant, because the intestine is a highly immunogenic organ, as you can see, and needed a powerful drug that we developed in 1990s in Pittsburgh. Over my journey for more than 30 years that I went through despair and hope. And when you believe in God and you believe in your patients, you will always succeed. This is a paper published in 2002, telling the whole world and the healthcare system in America that intestinal transplantation came to stay and should be approved as the standard of care for patients with gut failure. You can see here we were celebrating that the same year, and you can see my late mother was looking at on the table of the food they offered me, which was a bag of TPN. And for those who are not familiar with small bowel or multivisceral transplant, there are 4 different types. You can see in your left-hand side, the yellow colored are the transplanted organs, and the brown colors are the native organs. Here, isolated intestine, here a liver and the intestine, and the pancreas in between. And then you have the full multiviscera, means that you're transplanting all the abdominal organs except the kidneys, call it full multiviscera. And because of the shortage of liver organs, I was able to develop a new technique for something called modified multiviscera, able to save the liver and give the other organs, so the liver from the same donor can go to somebody else. And you can see quickly, here is the how the donor operation is done. And this is a teaching slide. I teach the residents and fellows and even the attendings early on that the intestine has foregut, midgut, and hindgut. And that is actually a slide behind the notion, everything I was able to innovate in surgery. You have to know this by heart, and the surgeons have to be familiar with this very, very clearly. This is a GPS for the donor and recipient operation or any abdominal surgery. This is the intestine in the pocket before we put it in. This is multivisceral in the pocket. Also, you see the stomach, liver, intestine, pancreas here. And the spleen, usually we take it out because of many reasons. So we don't give the donor spleen to the patient. And this is a 3 days old donor that I was reluctant to use. You can see the organs are smaller than my hand, but the father was with a gastroenterologist from Ohio here. And he said, please try. So I did use it. The reason I didn't use it because these organs are thrombogenic. They're not mature enough to protect the vascular system from thrombosis. Here is if you're familiar with a video or a series called Surgery Saved My Life on the Discovery Channel. This is the example of the patient. The series is about my personal life and what I did for multivisceral transplant, and it's about an hour video. It's in YouTube. Whoever interested to watch it, is a very interesting movie to watch. This you can see on your left-hand side, all the organs are gone, except the diaphragm and some vascular clamps on the cava and the aorta. You can see here, I was doing a barbecue for this patient. And then you can see the organs back in, and life came back to them, bi'iradatillah. Here is the paper I published in 2009, showing our experience with 500 intestinal multivisceral transplant, which was about 1/3 of the transplant worldwide. This is an example of a success. This is a girl from Paris. She's 32 years after transplant, isolated intestine. She was transplanted when she was 6 months old. And then this Tracy also transplanted her in 2001. And now she's married and have kids, and she was about 3 years old. And you can see she was trying to get close to me in the picture. And this is another example, also patient. This girl also is about 39 after liver transplant. She had a malrotation syndrome, was not diagnosed, and she developed midgut valvulus after the liver will give her intestine. In 2 weeks, I'm presenting a new operation for gut malrotation at the American Surgical Association, which is the highest prestigious surgical society in the history of surgery. This is another example of patients that I did them when they were kids and now married, and they have their own kids. Transplant has limitations, and as you can see here, rejection intestine is a highly immunogenic organ. They can reject. You have to keep an eye on them. And this is a problem I have to tackle before I introduce a small bowel transplant in Egypt, and for other reasons too. This is an example of chronic rejection when the intestine becomes very atrophic. It becomes like very small, tiny piece of bowel, and when they develop fibrosis and arteriosclerosis of the intestine. Another one thing that I never want to see is when the patient develops graft versus host disease, means the organs reject the recipient, and it's fatal in almost every case, except one patient I was able to save. This slide, as I presented many times, that I feel ashamed that Africa is the only continent that I was not able to introduce small bowel or multivisceral transplant to, hopefully with the transplant team we have there now, we can within few weeks, a few years, we'll be able to have you can start doing anything you want, but before you do anything, make sure you can succeed. I think the small bowel multivisceral transplant, it will be the daily operation for patient even with chronic gut disorders without development of gut failure, if we can achieve tolerance. Because of the problem with the small bowel multivisceral transplant, I moved into something that we can use or we can do to restore the nutritional autonomy of the gut and eliminate the need for TPN as well as for transplant. And I tell all the patients that nothing better than your own gut. And because of the suffering I had over the last 3 decades, I said, well, I need to do something for some patients who still have some of their intestine that I could rehabilitate. And that's what's behind the revolution of the gut rehabilitation. You can see here, there is a new agent called enterotrophic biologic agents. One of them with the growth hormone, and then I have the privilege to approve it with the FDA in 2002. And there is a new drug called GLB2 or Gattex. It's expensive. It costs about $200,000 a year, but it is a very more effective than the growth hormone. And there is now they're working in an analog will be cheaper, and that's hopefully that will help us to introduce it to in Egypt within a year or two. Bowel lengthening, this is called Bianchi operation, and this is called the step procedure. That you cut the intestine in zigzag way. Did quite a few of them in Egypt over the last 4 or 5 years when I visit. And I developed a new procedure for the colon called coloplasty as well. And then here what you can see, if you have the patients and the scales, you definitely can save every inch of bowel. This is a patient with Crohn's disease. And then you can connect everything else. And my late mother used to say, كتر البكا يعلم النوح، مش كده؟ ولا أنا بقولها بالعكس. So when you suffer and when you see the patient suffering, you really try for you to suffer better in the operating room, and then they are free to go. They don't need immunosuppression. They don't need anything, and they can enjoy their life. In the second phase of my career, when I moved to Cleveland, because they have enough material for such patients, then I developed a program called Center for Gut Rehabilitation and Transplantation. You can see here, this was the product of the 10 years I have been here at the Cleveland Clinic. And that's the reason now I know why I moved to the Cleveland Clinic, because everybody in the world was saying, why did you leave Pittsburgh? God does things for many reasons. And this is the paper. It's actually one of the landmark papers in the field. You can see here, I moved from transplanting everyone to rehabilitating those who have enough gut to be rehabilitated. And over the 10 years, you can see patients came to me from all over the world, and 10% of them international. Even in the United States, about 44% of these patients from outside the area, the tri-state area I have here. You can see here that out of 500 patients, 40 patients came to me from hospital to hospital. And even some of these patients were sitting in the hospital for a year. Nobody knows what to do with them. And the other patient was elective. Amr or Dr. Sarag, you ask me to stop when a time is over, okay? I really don't care. All I care is don't waste your time or my time. And if a mutual benefit for you guys, I will continue talking. This is a new classification I introduced in this paper for the types of gut failure. Is a surgical, when something goes wrong in the operating room, or it's mucosal when the disease affecting the mucosa and the absorption of the intestine. And one is the pump failure. Pump failure like the heart. The intestine is not any different than the heart. Actually, it's more complex than the heart for absorption and for pump. When you lose the pump of the intestine, I call it neuromuscular disorders, ectodermal and mesodermal, and that's what we call gut dysmotility. And I'm seeing a lot of patients in Egypt, and they may have to do with microbiota or something else. I'm not sure yet. And you can see here, this is, I divided the group into different types. And you can see here, each types had the different causes. Focus on the surgical gut failure, fistulas, vascular thrombosis. Bariatric surgery is another problem you guys facing in the Middle East. And I think maybe I'll show you some slides how I fix them. And those with the mucosal disease. Before I tackled the bariatric surgery problem, I showed the picture for the pioneers in bariatric surgery worldwide, so that I would attack them before they attacked me. And I can see here, this is the diagram showing how I handle the patient with gut failure, mention the anatomy of the gut, the cause of gut failure, and if the liver is good or not. And this is the algorithm. If you're interested in the 2019 papers published 2 years ago, you can read it, and that will help you to understand that. And you can see I try to do everything possible to avoid need for transplant. But when transplant is indicated, it must be done. And this is the, you can see the different types of surgery. And patient who didn't have a transplant, a small number of patients, and that die from TPN failure. This is another seminal slide showing the development of the gut, the embryology, and this is the basis for everything I do. I can show it to you here. The two major principles behind the innovation in the surgery. You have to restore the alimentary flow, and you have to spare all native organs. This is types of gastric surgery that they do for some of these patients. You can see here, like the Italian tailor, وزينا واحنا صغيرين لما كانت امك تقعد تخيط الجلابيه او البيجامه 20 مره علشان ما عندناش فلوس نشتري بيجامه جديده. That's the same principle. It really is. And you can see here some innovative procedures when these patients failed any surgical intervention by any surgery in the United States. They come to me, and you can see here I created something called the neostomach. And it's like the J pouch, but I reverse it in between the esophagus and the stomach, because maintaining the alimentary flow is very, very essential for the gut homeostasis. You can see here, this is the patient with Crohn's disease, ate most of his duodenum, and they took piece of his colon and connected there. Any surgeon will do Roux-en-Y, but that it should be obsolete. I have been told to write an atlas on innovation in surgery and gut surgery. Hopefully I'll do it before I die. Now, also I do interposition grafts. You can, any piece of bowel you have, you can restore the continuity. I don't want to go you through all these details, but all these different surgical techniques. This is the step procedure to lengthen the bowel. And this is the new procedure I introduced 2 years ago called coloplasty, the same principles. For the gut dysmotility patient, there is a new operation called trifecta, introduced 2 years ago, and use it for some of the Egyptian patients, and they're really doing good. You can recruit any piece of bowel you have, and old days when you have site-to-site anastomosis, and this becomes dysfunctional. Then I disconnect them, I connect them back together. The دايما كويس with surgical techniques are helpful. You can lengthen the bowel every inch of the bowel counts. You can see here, patient with portal mesenteric venous thrombosis. In the 90s, I used to transplant them. Now, if they have normal liver functions, I could create, this is a chronocaval shunt. This is a patient of gastric bypass, and everything went sour in Qatar, came to New York, and they made him worse. You can see the esophagus is disconnected, the stomach is disconnected, no intestine, fistula and the duodenum. I took him to the operating room, and they connected him. And then, because he doesn't have enough bowel, I have to control the infection, and I give him a transplant. This patient was behind my success, بإذن to bury my mother في المعلات بالحرم. Now, here is the patient before, and you can see all the surgical techniques. Takes time and efforts and skills, and tawfiq min Allah. Here is the outcome. You can see the outcome is wonderful. Transplant, total population, the 500. TPN is less, but you still can save them. Causes of gut failure, causes of death, the patient who died, medical from TPN or autologous reconstruction or transplant. Maybe too much details for you. With this data, I was able to establish a predictive model to tell the surgeon or physician when patient can go for gut rehabilitation without a transplant with a good success rate, or patient can go for transplant from the outset. Here is the achievement of nutritional autonomies based on transplant, reconstruction, or no surgical treatment. These are the cumulative incidence of discontinuation of TPN and achieve nutritional autonomy, or I call it restored nutritional autonomy, called RNA. We developed the model, is actually in the app and the computer, the iPhone app, that you can look at it, and will help you if your patient can go in it. I call it Kareem RNA. And here is just another example showing the primary disease can affect your outcome. You can see here, the worst one is this one here. The purple is the neuromuscular, because whatever we do, we're trying to get away with the primary disease, but you really cannot change the neuromuscular disorder much, but you can try to help the patient with other innovative things. These are the nutritional indices, transplant versus autologous reconstruction. Try to convince the people in the field that if you have surgical skills to do autologous reconstruction and the patient has enough bowel, it's better for them. And this is the predictor factor we used to establish the model, and then how did we develop it. And this is the model that you put numbers here, and then it will give you an idea exactly what you're gonna go. If you are familiar with the gut, citrulline is the marker for the enterocytes, and you can see here the linear correlation. Quality of life, significant improvement. Just focus on this slide. Patient with transplant on about 15 medications a day. Patient with autologous reconstruction, 0 to 1. That's more enough for me. Here, I was able to establish the notion that the gut-brain axis, you can see patient with neuromuscular disorders that have the highest neuropsychiatric disorders, and that is because of the bacterial overgrowth and change in the microbiota. You can see the cost of living here, the cost of the procedure of the treatment. Cost in the United States about $70,000 for autologous reconstruction, $175,000 for the liver-free transplant, means intestine and pancreas, and for the full multivisceral goes to close to $500,000. This is the algorithm we developed to help with the young generation how to take care of this patient. These are my team in the early phase of my life, and this is the current ones. And I would love to share with you that until Mr. COVID goes away, Then we'll go back and try to finalize the CAF Foundation to help with the poor people in the Middle East. I have 400 or 500 text messages on WhatsApp for really patients need some help. These are my hero, Farouk, Allah yarhamu, that when I started my career and my journey, Dean Warren, when I learned how to do portal hypertensive surgery with him, and my last hero who passed away 2 years ago, and we had a lot of genetics similarity in common, and he always have been interested to know what I'm gonna do for Egypt. I thank you very much, and I greatly appreciate your time, and I hope I did not waste your time.
Thank you so much, Dr. Karim, for your very nice resume.
Glad to hear any question or you have anything.
If anyone have any questions, Dr. Karim? Yes.
Dr. Karim, always a pleasure to listen to your talks. This is Mohammed Shariba, transplant hepatologist at the UAB in Birmingham, Alabama. I wanted to ask you about the Treg therapy. Did it offer any promise in promoting that tolerance that you told us about in the multivisceral transplant patients, increasing the Treg population?
Not really. We have some trials, and really so far that I haven't had a chance to have a large series. If you remember the history, there's a paper in the Transplant International I wrote, I think 15 years ago. I started with the, after 1995, the results were not good. So I started put the program in moratorium, and then we did the bone marrow augmentation. It didn't work out. And then I used the irradiation for about 15, 20 patients. It did work very well. Irradiate the allograft itself to get rid of some of the lymphocyte load in the submucosa. It did work very well, but the patient developed mesenteric sclerosis. And then used the induction or preconditioning therapy, which is still we're using now. We use the Thymo and then the Cambath. I'll be glad if you have any access to the Treg. I think you guys have it to some extent to it. The liver is a immunoprotective organs. You really didn't want to do anything for them for liver. Liver takes care of itself. But with the kidneys, you know, there was some trials, and I think, I didn't know were you involved in that or not. Alan Kirk and others, and then what's his name, the guy from in California, was Stan. But really nothing, we never tried with the small bowel and multiviscera. So I'll be glad if you have any access to anything I could use, I will.
Thank you very much.
يسمح حضرتك, you know that we have a liver transplant program here in Egypt. We have a lot of patients performed morbid obesity surgery. Now we have
up a little bit.
You can hear me, Dr. Karim?
Yeah, I can hear you, but I barely I can hear you.
And now we have a lot of patients transferred to our unit after morbid obesity surgery with gut failure and liver cell failure. The intention is to transplant them with liver, but we found that they have gut failure after morbid obesity surgery. When you can assume that this patient with reconstructive surgery, he can benefit from reconstructive surgery, and then we have a reversal of the liver insult later on without transplantation. And when the decision is multivisceral transplant, including the liver?
Well, if I understand your question correct, is this arm?
Yes.
Okay. So you guys doing a wonderful job. You're doing a great number of, except in the COVID era now, but everything hopefully will go away. You're doing a great number of liver transplant, and you guys have a great success working as a team at all levels. So I'm proud of all of you. For the, if I understand your question correctly, that you have patient with some GI problem and liver failure. It depends on your definition of the liver failure. You know, if you've got high serum bilirubin, is he cirrhotic? Is it a portomesenteric venous thrombosis? Liver biopsy would help in this patients with the patient at the stage that you can do reconstructive surgery first or do liver transplant first. At the present stage, I don't think, unless we have a team learn how to take care of this small bowel transplant is the procedure. It's not a big deal. It is a deal, but it's not a big deal. But the problem in the post-operative care. That's why I have a few fellows now from Egypt that with the promise they're gonna go back. If we have a team for post-operative care that can, intestine is an unforgivable organ. You cannot go on vacation for a weekend and come back and Monday patient would be dead. You have to have somebody on the top of them. Once they have a suspicious of rejection, they must be treated and confirm the diagnosis immediately. So liver intestinal transplant at the present time, I don't think that's something I would entertain in Egypt, but which comes first? If you patient is in liver failure and you cannot tolerate gut reconstruction, then you do the liver transplant, you keep them on TPN for a few weeks or whatever, and then we can do the gut reconstruction for them. If the liver is in a shape that will tolerate the surgery, then you do the reconstruction first and then you do the transplant. Doing both at the same time will be a problem from infectious standpoint. Other thing also will determine your decision is if the patient, what kind of gut failure they have. If this is a disconnected gut, if this is fistulas, if this is Crohn's disease, if the disease under control. You need to go back to the slide I show what the underlying pathology in the gut. And that will help you to determine which one would be done first.
Majority of patients after malabsorptive morbid obesity surgery with a slight degree of liver decompensation.
What did he say?
Patient after morbid obesity surgery, malabsorptive type,
Right.
post-operative, they have decompensation, gut failure with a degree of liver decompensation.
Right, right. Well, I didn't know what degree means. Again, it's applied the same thing. If the liver, you decide, you make your decision as regard the status of liver dysfunction based on liver biopsy, biochemical data, and this is a really most. There is another thing. So you get the look at the chemistry, you do the liver biopsy, and if your liver can tolerate the surgery, I would do the reconstruction of the gut first. And if the liver cirrhosis or the liver disease, it's not severe, this will be reversed. And if you read the paper I published on 2015, I was not bored. In 2015, I'm showing some histology that was reversal of the liver damage after reconstruction of the gut after bariatric surgery. So it depends on the extent of your liver disease. It's only cholestasis or steatohepatitis then I would not worry. If the biochemistry is good, or the system is vascular system is open, I reverse the gastric bypass. You reverse it in the right way. Again, you follow the two principles: restore the alimentary flow and save every piece of the bowel. And then you wait. Most of this patient, most likely the liver will recover unless they already have advanced cirrhosis. So the liver biopsy will be very helpful for you, but gut reconstruction, it's not just a term. It's really how it is done and how can you efficiently reverse the process. Because don't forget, the liver is in the mercy of the gut. There is a connection between the gut and the liver as much as between the gut and the brain. So, but if you already have advanced liver disease or cirrhotic liver, then you do the liver first and then reconstruct the gut.
Thank you so much. Waiting for your next visit.
انا مش مصدق بس لما تشوفني البس البتاع الماسك لغايه ما عشان ما ابوسكش على بقك.
متشكرين جدا دكتور كريم. الحقيقه you are doing a great job in the world and in Egypt.
I'm so jealous because you lost some weight. You look beautiful. You look wonderful.
ايه؟
You lost some weight. You look fantastic.
بس دكتور سراج
We waited for you. A lot of patients wait for you.
دكتور سراج.
He's American, you know him.
دكتور سراج.
He is asking when you coming. Professor Bassiouni want to ask دكتور كريم.
أنا بس طبعا يعني دكتور كريم he is my age and he belongs to Mansoura where I do. I miss you يعني طبعا. I just wanted to say something about the liver dysfunction after bariatric surgery.
Yeah.
Actually, it had been reported that plenty of cases the MAFLT or the NAFLT improve after bariatric surgery. This is true.
Yes.
But some of the cases they get worsened because of three factors actually. Factor one is severe protein malnutrition. Factor two, because of the what we call the lipotoxicity, because plenty of the adipose or the mesenteric fat, they inflow heavily inside the liver, and it may cause toxicity. Number three, because of the bacterial overgrowth, small intestinal bacterial overgrowth. These are the factors that probably may affect the liver and worsen the function of the liver. And many of them, as Dr. Amr said, they sometimes need liver transplantation, or many patients we saw, they died because of the liver cell dysfunction.
Well, I give you the answer to brief your answer. Who is older, you or me? You look older than me, man.
No, we are the same age. انت مواليد 50 مش مواليد 50.
Listen, okay, listen here. I'll give you the what I told all your colleagues, the picture I showed. The
Yes.
treatment for morbid obesity is biological therapy. The history will come back, medical history will tell us in 20, 30 years that what we did was a crime, okay?
Yes.
It's not a crime right now because you're trying to help this patient as much as you can. You're changing the anatomy the gut created. If you remember old days when you were young, we used to do root and wine on every single patient, okay? And gastric resection. Bariatric surgery will be obsolete when medicine came to discover the connection between the brain and the gut.
Look,
So
I have
what you say is a good, beautiful
Yes.
exercise.
This is what
But-
I say. Well, this is what I say in every lecture I give.
Good.
That this is not
I'm
this is
glad
not
to
the
hear.
ideal way to treat morbid obesity, and one time it should stop. But this is the only available way that we have. We work because the physicians are not yet to the level of giving the solution.
I agree with you 100%. I think we're too old for that.
Yes.
That will wake us, or they'll come and visit us in heaven and tell us exactly what they found. Okay.
دكتور كريم
ماشي.
دكتور كريم بيه،
Yes.
انا بس في جات لي بيبر كده من الفلور احب اسمعها لك لان انا عارف انها تسعدك جدا. انت سامعني كويس؟ سامعني؟ الو، حضرتك سامعني يا دكتور كريم؟
ايوه سامعك حبيبي.
في من الفلور حد باعت لي ورقه بالعربي كاتب فيها: اسعدنا ان تتواجد صوره والد ووالده الدكتور كريم ودعاءنا لهم بالرحمه كما ربيا هذا العالم.
الله شكرا يا حبيبي. يا اشعر جسمي اشعر يا حبيبي.
دكتور شريف، يعني انا اول مره اتقابل معاك، طبعا احنا بنتكلم تليفونيا وانا هتواصل معاك تليفونيا بعد الميتنج نتكلم شويه.
We need to get your paper done. I'm gonna kick some ass ولاد الكلب الخواجات دول ان شاء الله. I'll get it done.
Now we move to the very important lecture on the updating of bariatric surgery for morbid obesity. Professor Fahim Bassiouni is a pioneer of general surgery and especially the bariatric one. اتفضل يا دكتور فهيم بيه.
هو صراحه ما حدش يقدر يتكلم بعد كريم ومجدي، يعني ما يصحش.
معلش هنتفاهم معاه. دكتور كريم هنعمل له قعده عرب كده ونتفاهم معاه.
هو الحقيقه طبعا he gave يعني a lot of information that no I myself I couldn't follow. البرزنتيشن باينه مش كده؟ البرزنتيشن موجوده عندكم؟
موجوده وواضحه يا بيه.
اوكي
واضحه يا بيه.
هو اكشولي احنا قصه الموربid، يعني the story of morbid obesity is not a surgical issue. It's an issue for يعني everybody, and we need to understand each other, and we need to work together to reach a solution, because the problem is not just a surgical problem, as Professor Karim said. Yes, the number is very big too. 2.1 billion adults are obese all over the world, but those who fulfill the criteria of surgical treatment, the proper surgical treatment, are no more than 25 million persons all over the world. And these are the red areas where the percentage is more than 30% of the population obese people. The etiology, as I said, is a multifactorial between genetic, hormonal, environmental, behavior, so many factors. So you cannot just solve this with a single solution, whether by diet, whether by surgery, whether by whatever. And it looks as if it's just a fat or some person, but the problems are much more than that, and the mortality is quite linked with the degree of obesity. It seems that we go finally to the metabolic syndrome, which is a combination of truncal obesity, hypertension, diabetes, dyslipidemia, with many definitions. WHO, American Heart Association, International Diabetic, National QC Education Program, European Group of Insulin Resistance, so many definitions of this. But the etiology is, the core is in the insulin resistance, where this insulin, I'm just trying to link between a bit between the physicians and the surgeon. The insulin is not just a hormone to burn the sugar. It interferes with actually every metabolic activity of every cell in the body. For example, this is how insulin creates a sort of dyslipidemia, and how it raises the level of the very low dense lipoprotein and causes hypertension. And this, what we have been talking about how does it share in NAFLD, not NAFLD, actually, it's called MAFLD, metabolic fatty liver disease, where there is a combination between genetic factors, insulin resistance, gut signals, microbiota, and we have before the two hit theories and now the multiple parallel hit theories, and eventually the effect is on the Kupffer cells and the stellate cells, and eventually we have the cytokine or the injurious cytokines and the fibrosis, and finally the liver cancer or hepatocellular carcinoma. And it's the most common cause of hepatocellular carcinoma, third cause of hepatocellular carcinoma, and the most common cause of probably liver cell failure. Dr. Karim just mentioned the relation between the brain and the gut, and eventually the arcuate nucleus of the hypothalamus is the highest control. This is affected by fat hormones, by GIT hormones, by vagal stimulations, which is affected also by chemical and mechanical stretch of the stomach. And eventually we have two directions. We have the direction of energy homeostasis or energy balance, and the direction of food intake and the appetite. And it has been proved now that the GIT, as Dr. Karim said, is a very big endocrinal organ. It's not just to take food and absorb and that and excrete. We have three areas, the stomach and the foregut and the hindgut, who are full of signals and neuroendocrine hormones that share in the process of this obesity, positively or negatively. Also, the fat, the adipose tissue, is a highly effective endocrine organ. It had been proved that, and especially with the visceral adipose tissue, which pours its cytokines and its substances, and also the fatty acids directly into the portal circulation and then to the liver. And some of these substances is being understood, and many of them are being still under investigations. We know that there is something called the leptins, which decrease food intake and increase energy expenditure. And we know adiponectin that, by the way, in obesity, there is some sort of leptin the resistance. Although it is high, yet there is resistance. And we have adiponectin that increases the insulin sensitivity and increase glucose uptake and decrease the gluconeogenesis. It helps, it's pro-insulin. And we have also resistin and so many other substances. This resistin is against all what have been mentioned. The visceral fat had been claimed to affect or create an internal inflammatory state that is responsible for the insulin resistance and the malignancies and so many problems. This is because the hypertrophic adipose cell inside the body, under the effect of heat and the pressure, it swells, it attracts chemokines to the macrophages, and then we have inflammatory cytokines like tumor necrosis factor alpha, interleukin 6, B, CRP, and eventually we have some sort of adipocytokine dysregulation, because we have good adipocytokines like the adiponectin, and we have the bad adipocytokines, and in such case we have a sort of dysregulation between these two factors. Dr. Karim also talked about the normal microbiota. We have our gut actually are divided or having two types of microbiota. The good microbiota which are called the bacteroidetes, and we have the bad ones that are the firmicutes. Firmicutes are pro-inflammatory and obesogenic, while the bacteroidetes are the reverse. In obesity, there are two things happen. Dysbiosis, that is increase of the bad bacteria on the expense of the good bacteria, and also the decrease bacterial diversity, because we have so many other tribes, maybe something like 5 tribes. So diversity of the bacteria helps or can be good. I'm sorry, because I'm now, by the way, I'm now under COVID. I've been in COVID for 7 days, so forgive me if I'm going to cough. Anyway, the role of the microbiota is by energy harvesting, by breaking down the food so that more food can be taken. Also, lipopolysaccharide, we know that gram-negative bacteremia or septicemia or whatever, in the gut, there is lipopolysaccharides related to the bacteria released into the systemic circulation. This happens because of the barrier of, there is supposed to be a barrier between this bacteria and the blood. And the Western type of food helps to break the barrier. And bacterial overgrowth creates a sort of inflammation that also breaks the barrier. So we have, there is induction of chronic low inflammatory state because of the lipopolysaccharide endotoxemia. In addition, these bacteria affect or modulate the gut polypeptide, in addition to release of a lot of fatty acids into the liver as well. The bile acids are really important. It had been proved that these bile acids, they have significant role in lipid and glucose homeostasis and in the regulation of energy expenditure. And if we divert these bile acids, regardless the type of surgery, then we have good effect on weight loss and improved and glucose lipid metabolism. So it can be hypothesized that this diversion or also the increase of the pool and the diversion, this helps in lipid and glucose, improving the lipid and glucose metabolism after bariatric surgery through changing the signaling pathways through the related receptors. This is the interior hepatic circulation, and almost 95% of the bile acids are reabsorbed in the at the end of the ileum. And by the way, there is an interaction between bacterial flora and the bile acids, where bacterial flora are affected by bile acids because they are bacteriostatic. And in addition, bacterial flora act on primary bile acids to create secondary bile acids that go to the liver and stimulate more secretion of primary bile acids from the cholesterol. So there is an interaction between bile acids and bacterial flora as well. Now, let's go to the surgical part. Our objective of why do we do surgery? We do surgery because we need sustained weight reduction. We need to improve the quality of life, including the quality of eating. We need to relieve the comorbidities or any morbid factors caused by the obesity, like diabetes, hypertension, dyslipidemia, whatever. And the treatment should be cost effective, and eventually we need to learn to prevent the premature death of patients. Well, how do these bariatric surgery work? They all work by restriction. Every surgery reduces the amount of food intake. And if you bypass part of the intestine, you have malabsorption, and it depends upon how much did you bypass. If you bypass or the stomach or minimized the effect of the stomach, then you have maldigestion. If you bypass the pylorus, you have dumping. And delivering the nutrients directly into the distal gut, probably they create some sort of neurohormonal mechanism. If you take part of the stomach, then you decrease the ghrelin. If you bypass the foregut, you have the foregut effect. If you deliver to the food to the hindgut, you have the what we call the hindgut effect. Also, manipulation of the microbiome. The intestine is a filter. So, the stomach is a filter against the bacteria. So if you bypass the stomach, then the ingested bacteria go directly to the small intestine, and they induce some changes. Also, we talked about the manipulations of the bile acids, or there can be a combination of all the previous factors or some of them. These are the criteria of the National Institutes of Health, American National Institutes of Health, and it's obvious that it's not just 10 kilograms increase or 20 kilograms increase or something that's not, I mean, there are 7 criteria that should be fulfilled before going to surgery. But of course, there are determinants of the outcome of surgery, like the age. Old age, they tend to lose less, but they need to lose less as well. While young age, they lose more weight, but they have a very long lifespan that they may regain weight as well. Males lose better than females, maybe because of the muscle bulk and maybe because of other psychological problems or psychological issues. The degree of obesity, higher obesity, above 50 and above 60, they tend to lose less weight. Metabolic and environmental characteristics like, for example, the basal metabolic rate of the patient, psychological condition, not at the time of surgery, even 2 years, 3 years, even 10 years after the time of surgery. If these things change, patients can regain weight. Individual risk factors like inability to move, locomotive problems, also these minimize the outcome. And if the patient had done before a trial to lose weight, whether by diet, those who reduce weight good by diet, they lose weight better by other surgery. And those who give good, bad outcome after the first surgery, usually they give bad outcome after the second surgery, and we have to understand that. This is the history of, I won't go too much, it started by jejunal bypasses, and the very early gastric bypass procedure in the 60s actually, last century, and it was a single anastomosis and a bigger size of transverse stomach. And then the idea of partition, make partitions of the stomach, first transverse and then longitudinal. This was caused vertical gastroplasty. And Scopinaro, the Italian, came with the very strong, very tough malabsorption procedures. That's biliopancreatic diversion with severe malabsorption and also severe dumping. That was modified Hess and Hess through the duodenal switch by keeping the pylorus to minimize the dumping, and also elongating the common channel that is a combination between bile and the food or the alimentary channel. So this became 100 centimeters to minimize, just to minimize a little bit the degree of malabsorption. And in the 1994, came laparoscope, and we started the Roux-en-Y gastric bypass with the modification of adding a band, because adaptation. Dr. Karim talked about adaptation. Adaptation happens actually in the GIT in all directions, including dilatation of the gastric pouch. So that's why they sometimes used to put a band on the gastric pouch to slow down the flow of the food through the gastric pouch. And we have so many controversies. I won't go too much, but it's about the pouch size, and it's about the technique of doing the gastrojejunostomy, and it's about the length of the biliary limb. And now we tend to increase the biliary limb to 100 centimeters to induce some more, because gastric Roux-en-Y gastric bypass is considered more restrictive than malabsorptive. So we are trying now to increase the degree of the malabsorption a little bit, and also the alimentary limb, short one and a long one. These are controversies. Lastly, another modification was introduced, which is the mini gastric bypass, which is not mini actually. It's mini for the surgeon, not for the patient, because it has more degree of malabsorption and more nutritional complications, and it is called one anastomosis gastric bypass. We should not forget also the gastric band that started as not adjustable and then adjustable, but it's because of the bad outcome now it is getting much less used. Under trials is the gastric pacing, where we introduce a sort of wire to control the rate of evacuation of the stomach and the degree of satiety as well. These are the precursors of the sleeve gastrectomy. That's the most commonly performed surgery now. First, the Magenstrasse, and what I said, I mean the duodenal switch, where we divide, we elongate the gastric, the gastroplasty, or remove part of the stomach, but keeping the pylorus. These are the precursors of the sleeve. And then the sleeve with modification, ileal interposition or ileal transposition. These are also modification, but the standard surgery is now, we have 3 standard surgeries. The band, which is almost being withdrawn, the Roux-en-Y gastric bypass, and the sleeve gastrectomy. These are the 3 standard surgeries up till now. But there are special situations that where gastric bypass is really difficult to perform, and it's better to go for sleeve gastrectomy, like extreme obesity, super and super obesity, males with android habitus and difficult abdomen and too much fat inside the abdomen, the extremes of age where intestine cannot be used, like in Crohn's, where in adhesions, and in difficult patients with ASA scoring, which is, the patient cannot tolerate a longer surgery. In sleeve, we remove almost 75 to 85% of the stomach, but this is not a dictum, because it depends upon the size of the stomach and the shape of the stomach. So there is nothing called we remove a definite number. Of course, we can control the distance between that we cut between the pylorus and the cut, or the distance up from the gastroesophageal junction, but still it depends upon the length of the stomach, and sometimes we have small stomach as maybe 60 cc's, or sometimes we have 150 cc's in different patients. This is another modification created by an Iranian Talipur, because that time they don't have staples. So this is a vertical plication, invagination of the stomach to minimize the size of the stomach. Again, this is an addition to the sleeve by anastomosing the duodenum to 200 centimeters jejunum from the DJ. This is another modification, but the anastomosis is to the distal part. Both of them to add a malabsorptive element, because the outcome of the sleeve itself is not always successful because of the change of the habits of the eating habits that happen to some patients, or the adaptation or the dilatation of the what happens to the sleeve. This is a direct also modification of the sleeve itself, where the anastomosis is 250 centimeters from the iliocecal junction to the sleeve itself and not to the duodenum, because anastomosis with the duodenum is a bit difficult. We have also experimental, some other, all what I have said are experimental surgery. These are experimental endoscopic procedures I think most of you are quite familiar with. That's the different types of balloons, the buttocks, the endosleeve, the pose, etc. But in general, now there is a growing, of course, because of the COVID, it's in the last 1 or 1.5 years, the number is getting less. But the last report is almost 635,000 cases done per year globally. And if we see this table until 2018, you can notice that the sleeve here is the most popular all over America, and the Roux-en-Y gastric bypass, which was the most common, dropped to 17. And we can notice also that the redo cases is increasing, in addition that some increase in the number of balloons. Well, if you ask a surgeon, which is the best treatment, single treatment mode for morbid obesity, of course, surgery. Yes, this is true. Surgery up till now is the best outcome, but you cannot rely on surgery alone. And if you ask again a surgeon, which type of surgery is the best, he will just tell you, my surgery. Everyone thinks that the type of surgery that he is selecting is the best surgery all over the world, which is not reasonable and is not. But in general, surgery is a good outcome. And to be fair, bypass gives the best outcome, and the band gives the less outcome as regarding the weight loss. Also, the change in the hemoglobin A1C, improving the metabolic factors. Also, gastric bypass gives the best outcome in treating diabetes, followed by sleeve, and the band is the least. Many other also comorbidities like hypertension, diabetes, dyslipidemia, asthma, heart failure, sleep apnea, all these improve after bariatric surgery. That is of no question, really. And now we have what we call the metabolic surgery. Surgery is not just for weight reduction. It's also to improve the metabolic condition of the guidelines of the International Diabetic Federation. International Diabetic Federation, that are physicians, they are not surgeons. They agree totally that definitely those cases of diabetes who are not responding to medical treatment or lifestyle, and they are on the class 1 obesity, that between 30 and 35, they may be offered bariatric surgery, especially if they suffer from cardiovascular risk factors like hypertension, like dyslipidemia, and if they have a history of heart attack. So this is the guidelines of the International Diabetic Federation, meaning that really this surgery is effective. Also, there is improvement in the mortality caused by different comorbidities of morbid obesity and diabetes mortality. It's obvious that it dropped in one report by 92%. This is a very famous slide. And this is not the only study. Also, other studies. The total mortality is reduced, ranging between 30 to 90% in different reports. So this bariatric surgery does something good. Are we safe? No, we are not absolutely safe. Absolutely, we are not absolutely safe because we have some problems like conversion, like bleeding, like leaks, wound infections, DVTs, pulmonary embolism, mortality. And we have this list of complications, and Dr. Karim mentioned some of them. We have bleeding, we have leaks. These are two nightmares. We have injuries because it's a surgery. We have ulceration. If you anastomose something, this is a surgery. We have obstruction because it's a surgery. We have reflux that's maximum with the sleeve and the band and the VBG. And it's there also even in gastric bypass, but it is much, much less. We have ischemia. We have nutritional problems that, as I said, can lead to maybe liver cell failure. And we have thromboembolic problems, including DVT and pulmonary embolism, including portomesenteric thrombosis and short-gut syndrome and intestinal failure. You just heard from the marvelous lecture of Professor Karim. And we have many psychological problems in addition to the nutrition. And we have what we call the failure. What do we mean by failure? By failure, we mean surgically, if you lose less than 50% of the excess weight, it means that your surgery did not do well. But I do not agree, because sometimes you are doing this to improve the comorbidity. So if this comorbidity improved after losing only 10% of your weight, total body weight, I mean, then you are doing well. But this is what the surgeons say, because probably they target more the excess weight loss rather than the other factors. Also, the quality of life should be good, because if you lose too much weight, if you are unable to perform, if you faint every time, if you are not able to eat, if you are vomiting all the time, this is not something good. If you have a complication that will affect your life, this is called failure. And we have scoring systems, objective, that will show to us how the surgery is doing. This is a very, very, very important slide. That is adaptation. Adaptation is, you know that we have physiology. You have physiology and I have physiology, but my physiology is not like yours. Yes, we have broad lines of physiology. Yes, but the intestinal motility in yours is not mine. The digestion in your body is not mine. The gastric motility and the activity is not mine. The colon activity is not like mine. So there are plenty of variations that will affect the outcome or help sometimes to fail the surgery. But of course, the type of surgery, if you do a less quality of surgery, or if you do, like for example, if you go on a man who is sweet addict and you offer him a band or a sleeve or a VBG, it means you just he's going to fail. And if you do the surgery not in the proper way, in the measures not in the proper way, then this will not do good. Dilatation, after the dilatation, can include the gastric pouch, can include the sleeve, can include the distance above the band or above the VBG, or can include even the intestine after the gastric bypass. And you heard something very good from Professor Karim El-Romagd. This is the GLP-2. This is present in the body, and there is compensation. There is, after surgery, there is increase in some cases of GLP-2. This will lead to dilatation of the intestine and increase in the mucosal pattern. So the absorption will become more. Also, the gut motility after gastric bypass. Sometimes some patients, they go directly to the WC after eating, and others, no, they have even constipation. These people, they absorb more, so they compensate more. So also, some of patients, they lose appetite after sleep, and after some time, they regain the appetite, or GLP-1 or PYY, they decrease after increase. So energy expenditure as well. Not all the patients, some of them, they save a lot of energy, so they not benefit well from the surgery. Some of them, they have complications. Some of them, some of bypass patients, they have gastric fistula, so they eat more, or even after VBG, for example. The change in the psychological, in the environmental factors, even after years, these also sometimes lead to failure of the surgery. And we know that we have something called the honeymoon. Every surgery in the first 1 or 2 years, every patient improve. But then the personal factors, the environmental factors, the psychological factors work, and then maybe he came back to worse. The deficiencies are there in the micronutrients and in the macronutrients. Especially, the deficiency happens in every patient, by the way, but it is of course more in the malabsorption procedures, and some of them are very difficult to treat, like refractory hypoglycemia, and many patients, they just faint in the street or faint when they are driving. Some also deficiencies like vitamin C, selenium, etc., etc. We should not forget that there are psychological complications like depression, suicide, alcoholism, change in the eating behavior, like for example, the sweet eating, emotional eating, binge night eating syndrome. All these changes that happen. But to finalize, in spite of this, if you go to the mortality of the general mortality of the bariatric procedures is much less than many other major surgeries like craniotomy, esophagectomy, pancreatectomy, even the hip. So, conclude, definitely obesity is a worldwide epidemic. We have a very big problem that's increasing, and it increased more after this COVID because most people stayed at home. Surgery gives probably the best outcome so far for morbid obese patients, but there are a lot of changes, as Dr. Karim said, in the physiology and in the anatomy. We induce a dramatic change in the physiology of patients and in the anatomy of patients. And this has its consequences, and it has its complications, and adaptations are there depending upon the nature of the human being and the nature of the physiology and the anatomy of the patient himself. And that's why we cannot work in different islands. We need you. We need us. You need us. We need you. We need to work together. The only way to treat this bad disease is work in a multidisciplinary team, either before the surgery or with the surgery or even after the surgery to correct the problems or to adjust the patient or take care of the patient. Thank you.
Thank you so much, Dr. Fahim, for your elaborate